Hi, this is Jessica Quandt, and today I'll be speaking about HyperIGM syndrome. First, in order to understand how this disease manifests itself, I wanted to give some quick background information on normal immune function. The body has two types of immunity: the B cell immunity, which is known as humoral immunity, and T cell immunity, which is known as cell-mediated immunity. When the body encounters an antigen, the B cell system first produces immunoglobulin M, or IgM, antibodies. There are other classes of immunoglobulins such as IgG, IgA, and IgE that are also very important in fighting infections. Normally, after IgM is produced, the other immunoglobulins are then produced sequentially during a process called class switching recombination. In order for this class switching to happen, the molecule CD40 on the surface of the B cell must interact with the CD40 ligand. Now that we have some background information, let's talk more about HyperIGM syndrome. HyperIGM syndrome is a rare immunodeficiency disorder. It is caused by irregularities in cell development and the cell maturation process of the immune system. It is characterized by normal or elevated IgM levels and inadequate levels of IgG, IgA, and IgE. Those with this disease will have poor antibody function. Now, some more on the pathophysiology of the disease. All cases are associated with defective class switch recombination that was mentioned earlier in the background slide. Most patients with hyper-IgM have CD40 ligand deficiencies, but it is possible that some individuals with this syndrome could have other deficiencies, such as these listed. In essence, these patients will have defective T cell responses and impaired immune function. Now let's look at the genetic component of the disease. 70% of cases are inherited as an X-linked recessive trait. The gene responsible encodes the CD40 ligand that we touched on earlier. Because females have another X to mask the disorder is only fully expressed in males. Other cases are inherited as an autosomal recessive or an autosomal dominant genetic trait, so males and females would be affected equally in these cases. Unfortunately, the gene or the genes responsible for the autosomal forms have not yet been identified. Lastly, this disease can be acquired. It can be associated with taking Dilantin, congenital rubella syndrome, T-cell leukemias, or lymphomas. It is important to note that all cases of this disease are rare. This disease is so rare, in fact, that the X-linked form affects 2 in 1 million males, and the other forms affect less than 1 in 1 million people. And parental consanguinity could be a factor in inheriting this disease, especially in the autosomal recessive form. As far as genetic risk, it is mainly an X-linked trait, so women will be carriers and men will fully express the disease. Women who are carriers will have a 50% risk of having their daughters being carriers and a 50% chance of their sons actually having the disease. Also, it's important to note that the carrier females will be clinically healthy, so they will not often know that they are carriers. For men with the disease, 100% of their daughters will be carriers, and there will be no transmission of the disease to their sons, since it is an X-linked disorder. Other risk factors besides the genetic risk factors include taking the medication Dilantin, being exposed to rubella in utero, having T-cell leukemia, or having lymphoma. Presentation of the disease usually occurs in the first or second year of life, so you may see these patients in a family practice office or in the pediatrician's office. The child may have recurrent respiratory or ear infections or recurrent fevers. They may also have gastrointestinal issues such as diarrhea and failure to gain weight. They may have enlarged lymph nodes or enlarged tonsils. or they may even have hepatosplenomegaly on exam. If the child is acquiring opportunistic infections, this is a red flag and should lead the provider to consider genetic testing and a referral to an immunologic specialist. The child may have pneumocystis pneumonia, other lung infections caused by cytomegalovirus or cryptococcus, and diarrhea and hepatosplenomegaly caused by cryptosporidium. Some labs are done by the primary care provider or the pediatrician, and some are done by immunologic specialists. Initial findings may include neutropenia, which can be chronic or cyclic, anemia, thrombocytopenia, markedly reduced serum levels of IgG, IgA, or IgE, normal or elevated levels of IgM, and decreased levels of memory B cells. To help come to a diagnosis, there must be a synthesis of clinical findings and patient and family history. Once other labs have been obtained and are suggestive for hyper-IgM syndrome, such as low levels of immunoglobulins, mutation analysis must be done to definitively diagnose the disease. The mutation analysis in those with the disease would show a CD40L deficiency. As the disease progresses, patients may develop autoimmune disorders, neurologic complications, liver disease, gastrointestinal tumors, or lymphoma, so these patients will be under the care of many specialists throughout their lifespan. Genetic testing and counseling is available for these patients and their families. If parental consanguinity is present or possible, genetic testing should be considered. Genetic testing can help identify female carriers and make prenatal diagnoses. Genetic testing has to be done at a laboratory that specializes in these tests that are needed. So here's a link to the genetic testing registry where you can find information on laboratories that are available in your area. It is imperative to have close coordination of the pediatrician and other specialists, such as these listed, to treat this disease. Patients will receive prophylactic therapies such as antibiotics, immunoglobulin infusions, steroids, and NSAIDs to help prevent infections, particularly those opportunistic infections. Bone marrow transplant has been effective in some cases of hyper-IgM and would be the only curative treatment. All other treatment is symptomatic and supportive. Here are some important points in client and family education. Patients with hyper-IgM syndrome should not receive live vaccines because they are so immunocompromised. However, it is very important that the patient's family members are immunized to help prevent infection. Frequent hand washing is also imperative, and patients should also avoid unpasteurized juices as recommended by the FDA. Also, family members should be educated on the availability of genetic testing and counseling. Resources are available for patients and their family members, such as these listed here, which include information on clinical trials, the Hyper-IgM Foundation, the Immune Deficiency Foundation, and the Genetic and Rare Disease Information Center, and here are all the links to those. In summary, hyper-IgM syndrome is a rare, predominantly X-linked disease. These patients are at risk for opportunistic infections, which could potentially be life-threatening. Red flags you may encounter in your office include young male patients with recurrent fever and respiratory infections. You will need to refer these patients to an immunologic specialist for further testing. Care over the lifespan for these patients will be both extensive and interdisciplinary. And it is so important to know that genetic testing resources are available for these patients and their family members. If you have any questions, please don't hesitate to email me at jessica.rose.quandt@live.mercer.edu. Here's a list of the references I used for this presentation, and I hope you guys have a good rest of your day.